Hi everybody and welcome back to my channel. Today I will be talking about how to perform a history for a OSCE or ISCE examination at medical school. This history format can also be used when working as a doctor in real life. So please stay tuned to learn more about my specific approach to this. The first thing to remember when carrying out a history examination task as an ISCE is just remember to be as natural as possible. So first of all, if you were in a clinical environment or setting, ask yourself, how would you approach such a situation, and try and adapt that and good aspects of what you would normally do, intertwine that into your OSCE or ISCE format. So what I mean by that is, if in a typical clinical environment you would ask the patient to come to a side room potentially for privacy, or you would offer the patient a tissue if they seemed upset, in your OSCE examination do the same things, because remember, ultimately you are acting the same way that the actor is acting, so you will score marks for being as natural as possible, and your personality coming through will also stand you in good stead in terms of differentiating you from other people. So it's also important to ask other things such as, do you have anybody present with you today who you would like to be in the room with you? Obviously in an OSCE setting the patient or the actor is going to say no, but remember, that's what you would do in real life, so try and bring those nice little things that you do in real life through to this environment also. So after establishing the basics such as the patient's name and date of birth, begin by asking the first question, which is going to be an open question, and then you triple hit them. So what I mean by that is, you hit them with an open question, another open question, and a third open question. So the dialogue would go something like this. So, Mrs. Jones, you have come in today and you have informed my colleague that your vision is blurry in the distance. Do you mind telling me a little bit more about this? Mrs. Jones will then go into a dialogue as to how her vision has been affected. Once she completes all that she has to say initially, you then follow this up with the following statement or something to this extent, which says, can you tell me a little bit more about that, Mrs. Jones? Mrs. Jones then goes into another dialogue about potentially another aspect of how her vision has been affected. And then the final thing you ask is there anything else, Mrs. Jones, that you would like to tell me about how your vision has been affected? So there, at this point, you have hit the magical 3 open questions. It may seem a little tedious, however, you will glean and gain so much information from just listening to the patient, and through these 3 open questions it can help you to direct the closed questions that you will shortly begin asking the patient. So remember, listen very carefully and ask 3 open questions. So when you then come on to the closed questions section of the history station, it's important to focus on what you feel the potential differential diagnosis is, and this will be guided by what the patient has told you during the open questions component of this history station. So for example, if the patient has told you that they have a red eye which has been painful for the past couple of days, a few differentials that should be in your mind at this stage include angle closure glaucoma and uveitis. You would therefore ask specific questions about any sensitivity to lights, i.e. photophobia. You would ask about any previous history with such symptoms, which could indicate a repeat attack of uveitis. You can ask about nausea and vomiting and or headaches. which would point towards something like angle closure glaucoma. So don't use these closed questions without a specific purpose. Ensure that you ask them with a very specific differential diagnosis in mind, and remember, work through a differential list in order to try and understand the patient's complaint and in order to try and get to what it is that may potentially be going on. Other specific things that you could ask at this stage include how long have they had the specific complaint, when did it start, is it getting better, is it getting worse, does anything specific make it worse, does anything specific make it better, etc. Again, one specific thing that you must ensure that you ask in every history station and in real life is the ICE component of such a station. And ICE, if you're not familiar with the term, stands for ideas, concerns and expectations. You don't necessarily have to do this in a specific order, such as ICE. You may decide to break it up and ask ideas at the beginning of your history consultation, ask about concerns in the middle, and ask about expectations at the end. The important thing is to A, cover it, B, cover it well, and C, when you're specifically asking about concerns, ask this question multiple times, because usually in real life, as per your OSCE station, the patient will have more than one concern, and if you don't ask, you will not find out about what their concern or concerns are. The next component of a good history station would be considering some of the absolute red flag features of what the patient may be presented with. So in the context of the scenario that I described earlier, which was a painful red eye, the worst case scenario that a painful red eye could be is something like an angle closure glaucoma. So it's important that you ask a few red flag symptoms, such as, do you have any nausea or vomiting, and do you have headaches? This will help you to rule in or rule out not just some of the more common differentials, but some of the more serious differentials that you cannot and you must not miss. The final thing to then consider is if you're carrying out a respiratory history station, is to screen the system. So what I mean by that is, if the patient has presented with a cough and they've got they're producing green mucus, it's important to ask about the other respiratory symptoms, such as, is there any associated shortness of breath, is there any pleuritic chest pain? In addition to this, do they have any night sweats? And by doing this, you will do what I call screening the system, and that will ensure that you do not miss any important symptoms that the patient may have. So far, just as a quick recap, we've covered initially asking 3 open questions, then following this up with very focused, specific closed questions. The next component is ICE, red flags, and screen the system. Remember what I said, ICE can be asked at any point during the consultation, but it's important to cover it. Where you cover it, it's down to your choice. It's important to also go with the flow of what the patient is saying, and it may be inappropriate to ask it at certain stages if the topic and flow of conversation is not specifically channeled towards asking about ICE at that particular moment in time. The next section then of the history station is going into the more routine things, such as what's the patient's past general history, what's the patient's family history, what medications, including doses, the patient is taking, do they have any drug allergies, and then going into the social aspects of the history to include who they live with, do they smoke, do they drink, and at this point things such as driving and occupation may be relevant. By using the format that I have just described, you can adapt this generic history structure to every single history that you take within medicine. And what you do is use what I've described as a generic core structure and add in specific relevant aspects pertaining to another speciality. So for example, if you were on a pediatrics job, you would add in extra pediatric related specific questions such as when was the child born, how was the child born in terms of delivery, what's their development been like, have they had all of their immunizations, for example. If it was a psych-related history, then you would go into a lot more detail, for example, about a forensic history, and you would ask more about family structures and family dynamics. So what I'm trying to say is have a core structure, have a generic structure, and then learn specifics related to other subspecialties that you will need to ask about when carrying out a specific history for an exam, or if you are actually working in that particular job. So that brings me to the end of this short video about how to take a good history both in an OSCE setting and as part of your job when working as a doctor. Remember the key points, which are have a structure, be as natural as possible, and really listen and be empathetic to patients. It's important to also remember things such as try and chunk and check information. It's important to signpost when you are trying to steer the conversation in a specific direction, and it's also important to ensure that the patient feels listened to and you have fully acknowledged all of the concerns that they may have. Once you have taken a thorough history, the aim at this point should be that you should have a fairly good idea as to what is going on in terms of a diagnosis, and you should have a list of differentials also. What you will then be able to do is carry out a tailored focused examination which will help you to rule in or rule out conditions that are on your differential list, which will make you a lot more efficient in your job, and it will also allow you to build up and develop diagnostic skills and abilities which will serve you well in your career. Thank you so much for watching again. If you are new to my channel, please do watch my other videos which are available in the playlist section of my channel, and I hope you have found this video to be useful. Please do click the like button, the subscribe button, and kindly support my channel in its early stages. Thank you so much.